My name is Ho Sik-shin from Kosin University Gospel Hospital. It is because of God's extra help that I'm able to present at this press conference. I would like to thank the Minister of Health, Nation King, Religion King, the Kingdom of Cambodia, for inviting me and two professors who charity. Today's topic is how to slow progression of the diabetes nephropathy, importance of early intervention. Before we dive in, let's go over the key points. Early intervention is critical in the slowing diabetic nephropathy progression, as this is a growing global health issue. The disease is driven by metabolic, hemodynamic, and inflammatory factors, including loss activation, and oxidative stress. That's why regular screening of albuminuria and eGFR is essential for early detection and prevention of CKD progression. To slow diabetic nephropathy, we focus on lifestyle change like a healthy diet, exercise, and quitting smoking, along with lipid, blood sugar, and blood pressure management. The four key treatments include RAS blockade, SGLT inhibitor, GLP-1 receptor agonist, and phenylalanine, all working to protect the kidney and slow disease progression. First, I'll give you an introduction. This table presents the global diabetes projection from the 2021 to 2045. The prevalence of diabetes among the adult is expected to rise from the 10.5% in the 2021 to 12% in 2045, with the number of people with diabetes increasing from the 563 million to the 783 million. The global health expenditure due to diabetes is long projected to grow from the 960 billion in 2021 to 1,054 billion in 2045. This trend highlights the increasing burden of diabetes along-wide, emphasize the need for the effective prevention and management strategy. Diabetic kidney DKD affects 700 million people worldwide and has a threefold higher risk of all-cause mortality than people without DKD. This slide shows trend of ESKD disease due to diabetes. The prevalence of diabetes-related ESKD increasing from the 90% in the 2000 to the nearly 30% in 2015. Among the newly diagnosed ESKD patients, the percentage attributed to diabetes rose from 22% to 31% during the same period. This slide shows global diabetes prevalence projection. The global prevalence of diabetes is expected to rise from the 554 million in 2023 to 600 million by 2035, reaching 783 million by 2045. This table presents the global epidemiology of DKD and its major risk factors include hypertension, diabetes, obesity, and hypercholesterolemia. Diabetes significantly increases the risk of CKD with odds ratios ranging from the 1.75 to the 8.22 across different world regions. This highest risk is observed in Latin America, Southern Asia, and Eastern Europe. Hypertension and obesity also play critical roles in the CKD progression. This finding underscores the urgent need for targeted prevention and management strategies to reduce the global burden of DKD. This slide shows the progression of the DKD without the early intervention. DKD progresses through the distinct stage from the normal kidney function to microalbuminuria, macroalbuminuria, and ultimately the ESKD. Without the early intervention, kidney function declines progressively, leading to the severe complication and the need for dialysis or transplantation. Effect of early intervention on the kidney function preservation. Early intervention plays a critical role in the preserving kidney function in patients with DKD. Implementing strict glucose control, the blood pressure management, and renal protective therapies can significantly slow disease progression. This chart highlights the difference in kidney function, the preservation between the patients who received early intervention and those who do not. This visualization effectively emphasizes the importance of early intervention in slowing the progression of diabetic nephropathy. Let's turn to pathophysiologic mechanism of diabetic nephropathy. This diagram illustrates the key mechanistic drivers contributing to kidney damage and disease progression in diabetes. It highlights the three major pathways: the metabolic disturbances, hemodynamic mediators, and inflammation and fibrosis. Metabolic factors like ALOS and AGE triggers inflammatory response, while hemodynamic changes such as angiotensin II and aldosterone promote fibrosis. Additionally, chronic inflammation leads to a feed-forward cycle of pro-inflammatory and pro-fibrotic factors worsening kidney damage. This mechanism collectively drive glomerulosclerosis and tubular-interstitial fibrosis, ultimately leading to ESKD. Early intervention targeting this pathway is crucial to slowing disease progression. This slide shows the metabolic, the hemodynamic, and the inflammatory pathway implicated in the underlying pathophysiology of DKD, underscoring the need for multi-targeted therapies to halt the disease progression. First, metabolic dysregulation, including hypoglycemia and dyslipidemia, activates the pathways such as AGE raises signaling, leading to oxidative stress and inflammation. Second, hemodynamic changes like the altered sodium-glucose reabsorption and vasoconstriction further impair the renal function. Third, inflammatory responses, including macrophage activation and cytokine release, contribute to the progressive fibrosis. This interconnected mechanism highlighted the urgent need for multi-targeted therapies to slow DKD progression and prevent kidney failure. Let's turn to screening for diabetic nephropathy. DKD screening should be performed yearly, starting 5 years after diagnosis for type 1 diabetes and at diagnosis for type 2 diabetes. Screening involved spot urine LCR and eGFR test. CKD is diagnosed when the ACR more than 30 mg per gram, the eGFR less than 60 ml per min per 1.3 square meter, or other the kidney damage persists. If results are positive, confirm with repeated tests, evaluate temporary causes, and the use the cystatin C plus creatinine for better the GFR estimation. Early detection and evidence-based treatment are crucial to slow disease progression. This diagram illustrates the morphology of diabetic kidney disease based on the GFR and albuminuria categories. Classically, DKD H3 is characterized by high albuminuria, more than 300 milligram per gram, and the progressive kidney function decline. Some patients experience albuminuria regression despite reduced GFR, while others follow rapid decline in the kidney function, leading to the kidney failure. Additionally, a set of patients developed non-proteinuric DKD characterized by the declining GFR without significant albuminuria. These variations highlight the heterogeneous nature of the DKD and the need for the individualized disease management. Let's turn to traditional treatment for diabetic nephropathy. This diagram uses the temple analogy to illustrate the pillars of DKD treatment. The foundation includes lifestyle modification, lipid management, blood sugar control, and blood pressure management. These pillars represent key therapeutic strategies, including LAS inhibitor, SGLT2 inhibitor, GLP-1 receptor agonist, and non-steroidal MRA. Each pillar contributes to kidney protection by reducing inflammation, fibrosis, and metabolic stress. Together, these strategies form a comprehensive approach to preventing DKD progression and preserving kidney function. This slide shows a comprehensive care approach for managing diabetes with CKD. Key strategies including glycemic control, blood sugar regulation, lipid management, and risk factor modification. First-line treatment involves SGLT2 inhibitors, LAS blockade, GLP-1 receptor agonists, and statins, while lifestyle interventions such as diet, exercise, weight management, and smoking cessation play a crucial role. A multidisciplinary approach integrates education, self-management program, clinical guidelines, and risk mitigation strategies. Ensuring improved diabetes and CKD outcomes through the personalized evidence-based care. This slide shows outline a holistic approach to improving outcomes in patients with diabetes and CKD. Key lifestyle interventions include a healthy diet, physical activity, smoking cessation, and weight management, along the regular risk factor reassessment every 3 to 6 months. First-line drug therapy consists of SGLT2 inhibitor, metformin, LAS inhibitors, and statin. Additionally, treatments are tailored to individual risk factors, incorporating GLP-1 receptor agonist, non-steroidal MRA, blood pressure medication, and lipid-lowering agent. This personalized strategy ensures optimized glycemic control, cardiovascular protection, and kidney preservation for both type 2, type 1 DM, and type 2 DM patients. First, lifestyle modification is essential for the managing diabetes and the CKD. Key components include a healthy diet, regular physical activity, smoking cessation, and weight management. These strategies help improve the metabolic health, reduce the cardiovascular risk, and slow kidney disease progression. There are very few randomized controlled trials on diet in patients with CKD and diabetes. Therefore, dietary patterns that are beneficial for the general population and individuals with diabetes are also considered beneficial for those with both diabetes and CKD. In general, it is recommended to consume a diet rich in vegetable, fruits, and whole grain, dietary fiber, unsaturated fat, and nuts. While limiting processed meats, refined carbohydrate, and sugar sweetened beverages. Protein intake should be limited to approximately 0.8 gram per kg per body weight per day for patients not on dialysis. So while those who have started dialysis should increase their intake to 1 to 1.2 gram per kg per day. Sodium intake is recommended to be kept below 2 grams per day. Dietary decisions should be made collaboratively with the patient, considering cultural differences, cooking method, and cost to ensure a personalized and sustainable approach. For the physical activity, it is recommended that the individual engaged in at least 150 minutes of the moderate intensity exercise per week, tailored to their cardiorespiratory fitness and exercise capacity, while also avoiding a sedentary lifestyle. Recent studies highlight the importance of the resistance training, showing its benefit in improving muscle strength, physical function, blood sugar control, reducing inflammation, and enhancing cardiorespiratory fitness. For high-risk patients, a personalized approach to the type and intensity of exercise is necessary to ensure safety and effectiveness. Smoking cessation is strongly recommended for patients with DKD. Weight loss is encouraged for patients with obesity, diabetes, and CKD, as it can improve the health outcomes, particularly those with eGFR more than 30 ml per min. Lipid management in a patient with DKD, such repeated testing should be performed at a patient discretion when it informs the treatment decisions, such as assessing cardiovascular disease risk, evaluating adherence to repeat dyslipidemia treatment, etc. In pre-dialysis DKD patient, statin monotherapy combination, the statin and ezetimibe should be prescribed. Third, in patients with DKD on dialysis, initiating statin monotherapy or the combination therapy with statin and ezetimibe for primary prevention of CVD is not necessary. This slide shows the dyslipidemia in the DKD nephropathy, highlighting the characteristic lipid abnormalities in the CKD and dialysis patients. TG and very low density lipoprotein level increased, while the HDL decreased due to insulin resistance and impaired lipid metabolism. In CKD patients, the lipid abnormalities vary based on the proteinuria severity, with small dense LDL increasing in nephrotic range proteinuria. Hemodialysis patients showed the minimal lipid changes, while PD the patient frequently exhibited hypertriglyceridemia. These lipid alterations contributed to cardiovascular risk in the diabetic nephropathic patient. The SHARP trial studied whether lowering LDL cholesterol with simvastatin plus ezetimibe benefit the patient with CKD. The result shows the 70% reduction in major atherosclerotic event compared to the placebo. The treatment was especially effective in non-dialysis patients. Overall, the study supports cholesterol-lowering therapy in CKD to reduce cardiovascular risk. This slide compares the effectiveness of statin in CKD. The left slide shows a meta-analysis indicating that the statin reduced cardiovascular risk in a CKD patient, especially those not on the dialysis. On the right slide, the Aurora trial found that rosuvastatin did not significantly reduce the cardiovascular event in hemodialysis patients. This suggests that statins are beneficial in CKD but may not be effective in the dialysis patient. This slide shows the blood sugar management in patients with diabetes and CKD. Hemoglobin A1C monitoring is recommended to assess the glycemic control. The suggested hemoglobin A1C target range is less than 6.5% to less than 8%. Individualized based on the patient characteristics, though for those not on the dialysis. These guidelines help balance the glycemic control while minimizing hypoglycemia risk in the CKD patient. This slide shows the present treatment algorithm for selecting SGLT inhibitor in patients with type 2 DM and CKD. Lifestyle therapy, including physical activity, nutrition, and weight loss, is the foundation of treatment. First-line therapy includes the metformin and SGLT inhibitor, but their use is limited by the kidney function. In the case of metformin, the reduced dose if eGFR less than 45, discontinued if eGFR less than 30 or on dialysis. In the case of SGLT inhibitor, do not initiate if eGFR less than 20, discontinued in dialysis patient. Additionally, drug therapy is individualized based on the patient preferences, comorbidity, eGFR, and cost. GLP-1 receptor agonists are the preferred with other options, including DPP-4 inhibitor, insulin, sulfonylurea, and alpha-glucosidase inhibitor. These guidelines help optimize glycemic control while considering the renal function. Let's turn to the 4 pillars of therapy for diabetic nephropathy. This slide shows the present a 4-pillared approach to the managing diabetic DKD. RAS blockade reduced reduced hyperfiltration and endothelial dysfunction. SGLT inhibitor improve the tubulo-glomerular feedback, the lower proteinuria, and provide anti-inflammatory effect. Finerenone decrease inflammation, fibrosis, and tissue remodeling. GLP-1 receptor agonists address the metabolic dysregulation by reducing weight, dyslipidemia, and oxidative stress. These combined strategies target key pathways to slow DKD progression and protect the kidney function. This slide shows the nephron change in the diabetes and the effect of RAS blockade. In normal kidney, the afferent and efferent arterioles maintain the balanced pressure. In diabetes, the afferent arteriole dilates while the efferent arteriole constrict, leading to increased glomerular pressure and protein loss, which contribute to cell activation and inflammation. ACE inhibitor and the ALB help by dilating the efferent arteriole, reducing glomerular pressure and the protein loss, ultimately slow diabetic DKD progression. For patients with DKDs and albuminuria, RAS blockade are recommended, even if the blood pressure is normal. RAS inhibitors should be slowed, increased to the highest tolerated dose. Blood pressure, creatinine, and potassium should be checked within 2 to 4 weeks after starting or adjusting the dose. Treatment should continue unless creatinine rises by more than 30% in 4 weeks. This slide shows the mechanism of kidney protection with SGLT inhibitor, GLP-1 receptor agonist, and non-steroidal MRA. This slide shows the 4 key therapeutic approaches for DKD. SGLT inhibitor reduces sodium glucose reabsorption, restoring tubular glomerular feedback and allowing hyperfiltration. B. Various therapy improve the structural changes by reducing fibrosis, immune infiltration, and tubular damage. GLP-1 receptor agonists decrease oxidative stress, inflammation, and apoptosis. Non-steroidal MRA, like finerenone, blocked aldosterone-mediated inflammation and fibrosis, protecting kidney function. These therapies target the multiple pathways to slow DKD progression. Structural changes observed in the patient with diabetes and CKD include glomerular hypertrophy and thickening of the glomerular basement membrane, podocyte and detachment, and process effacement, expansion of glomerular mesangial cell matrix, immune cell inflammation, and interstitial fibrosis. Treatment with SGLT inhibitor, GLP-1 receptor agonist, and non-steroidal MRA help restore podocyte and decreases extracellular mesangial matrix, remodeling, immune cell infiltration, tubular damage, and interstitial inflammation and fibrosis. Hemodynamic change in the DKD are reversed with the SGLT inhibitor. In diabetes, the objective capacity for glucose in proximal tubule is increased by the upregulation of SGLT2 and SGLT1. As a result of enhanced glucose and sodium chloride uptake in the proximal tubule, solute delivery to the macrodensal cell of the juxtaglomerular apparatus is diminished, resulting in the altered tubular glomerular feedback. Adenosine release is subsequently decreased, resulting in the vasodilation of afferent arterial glomerular hyperfiltration and hypertension. SGLT inhibition decreases glucose and sodium reabsorption, thus increasing solute delivery to the distal tubule. These effects help restore tubular glomerular feedback, with a resulting increase in the production of the adenosine, leading to the vasoconstriction of the afferent arteriole and possibly vasodilation of the efferent arteriole, with the improvement of glomerular hyperfiltration and hypertension. This slide shows provided a practical guide for the initiating SGLT inhibitor in patients with type 2 diabetes and CKD. Patient selection. The eligible patient should have eGFR more than 20. So with a high priority candidate, including those with albuminuria more than 200 milligrams per gram, or high heart failure. Contraindications should include genital infection, diabetic ketoacidosis, foot ulcers, and immunosuppression. Third, intervention. Proven SGLT inhibitors include canaflorizine, danaflorizine, and empagliflozin, with education on sick day, the protocol, the perioperative cares, and the foot cares. The glycemic management. The patient at risk for hypoglycemia should receive the glycemic monitoring and potential dose adjustment. Third, volume management. The patient with diuretic use, fluid depletion, or AKI history should be monitored for volume depletion symptoms and may require diuretic dose adjustment. 4. Follow. Regularly monitor for adverse effects, review knowledge, and anticipate an initial drop in eGFR, which typically does not require discontinuation. This slide shows compares the This table compares SGLT inhibitor kidney outcomes trial, CREDENCE, DAPA, and EMPA. Each trial tested a different SGLT inhibitor in patients with diabetes and CKD. The primary outcomes should included eGFR decline, ESKD, and cardiovascular or the renal death, showing different risk rejection. These results highlight the renal and cardiovascular benefit of SGLT inhibitor in CKD patients. The DAPA-CKD trial showed that dapagliflozin significantly reduced the risk of more than 50% eGFR decline, ESKD, and death from renal or the CVD causes in the CKD patient, including those with type 2 diabetes. The hazard ratio was 0.61, demonstrating a clear benefit over placebo in slowing CKD progression. The EMPA kidney trial shows that empagliflozin helped slow the kidney disease progression in CKD patients, including those with and without diabetes. It significantly reduced the risk of the more than 40% eGFR decline, ESKD, and the death from the renal or cardiovascular causes. The hazard ratio was 0.72, providing its clear the benefit over placebo in the protecting kidney function. When starting SGLT inhibitors, a temporary and reversible drop in eGFR is common. This eGFR drip that happens more in patients on diuretics or with a lower baseline eGFR. If it stays within the 30%, treatment should continue. Diuretic doses may need adjustment to avoid fluid depletion. This slide shows the protective effects of GLP-1 receptor agonist against the hypoglycemia-induced kidney damage. GLP-1 receptor agonist activation increases cyclic AMP, which reduces NADPH oxidative stress, oxidase activity, thereby lowering ROS production and oxidative stress. Additionally, cyclic AMP inhibits apoptic signaling and suppresses NF-kappa B, leading to the decreases chemokine, cytokine, and adhesion and molecular expression. These effects collectively reduce inflammation, fibrosis, and immune cell infiltration, highlighting the renal protective potential of GLP-1 receptor agonists in DKD. For patients with type 2 diabetes and CKD who have not met their blood sugar goals with metformin and SGLT inhibitor or cannot take them, a long-acting GLP-1 receptor agonist is recommended. GLP-1 agonists help lower the blood sugar like insulin, but with a lower risk of hypoglycemia and added the weight loss benefits. Key options include dapiglutide, liraglutide, and injectable semaglutide. These medications are also studied for kidney benefits in the diabetes patients. GLP-1 receptor agonists help lower blood pressure, blood sugar like insulin, but with a low risk of hypoglycemia and the added benefit of the weight loss. Key options include the glutide, liraglutide, and semaglutide. These medications are widely used for diabetes management, especially in patients needing the both glucose control and the weight reduction. The AWARD-7 trial evaluated liraglutide in the patient with diabetes and CKD. Result shows the better eGFR preservation with deglutide compared to insulin glargine, especially in those with macrochloride albuminuria. These findings suggest dulaglutide as a renal protective option in DKD. The REWIND trial shows that dulaglutide reduced the risk of renal outcomes in patients with diabetes and CKD. This medication lowered the risk of composite renal outcomes in the new macroalbuminuria compared to placebo, highlighting its renal protective effect. The READER trial found that liraglutide reduced the risk of renal outcomes in patients with diabetes and CKD. It lowered the risk of composite renal event and the new onset macroalbuminuria compared to placebo, confirming its kidney protective effect. These studies looked at over 35,000 kidney transplant patients with type 2 diabetes. This study shows that those who used GLP-1 receptor agonist had a 61% lower risk of death and the 34% lower risk of heart and kidney complications. So, adding GLP-1 receptor agonist to post-transplant care could make a big difference. This slide shows the proposed update of 2024 KDIGO-CKD management guideline. So they suggested the GLP-1 receptor agonist semaglutide should be considered alongside other first-line drug therapies for patients with type 2 diabetes and albuminuria. In addition, GLP-1 receptor agonist should be a first choice consideration to manage the hyperglycemia. Finerenone blocks aldosterone from activating the mineralocortical receptor, reducing inflammation and fibrosis in the kidney cell. It lowers oxidative stress cytokine and adhesion molecules, offering kidney and heart protection. For patients with type 2 diabetes, CKD, normal potassium, and albuminuria, despite the maxed out loss inhibitor therapy, a non-steroidal mineralocortical receptor antagonist is recommended for kidney and heart protection. The Fidelio DKD and the Figaro DKD trial reported a relative risk reduction of 80% and 30% respectively for the primary composite renal and cardiovascular outcomes. Both studies were conducted in patients with type 2 diabetes and CKD across a wide range of the baseline eGFR and urine albumin UACR. The beneficial effect of finerenone were observed when added to optimize the RAS inhibitor therapy. Fidelio DKD trial shows that finerenone reduced the risk of kidney failure more than 40% eGFR decline or renal death, and also lowered the risk of cardiovascular event in type 2 diabetes and CKD patients. These findings highlight finerene's renal and cardiovascular protective benefits. Figaro, the DKD trial found that finerenone significantly reduced the cardiovascular event with a hazard ratio of 0.87 in type 2 diabetes and CKD patients. However, its effect on the kidney outcome was not statistically significant. These results suggest that finerene's primary benefit is cardiovascular protection in this population. Figaro DKD trial shows that the finerenone had a minimal impact on serum potassium level in patients with type 2 diabetes and CKD. The mean baseline potassium was 4.3 millimole per liter in both groups, with only a slightly increase over time. This finding suggests that the finerenone is well tolerated with manageable hyperkalemia risk. I would like to conclude with several remarks. The key takeaway from this slide is that early intervention is crucial in slowing diabetic nephropathy progression. DKD is a growing global issue, and its progression is driven by the metabolic, hemodynamic, and inflammatory factors, including RAS activation, oxidative stress, and fibrosis. Regular screening of albuminuria and eGFR is essential for early detection, allowing timely intervention to prevent CKD progression. Managing diabetic nephropathy starts with lifestyle change like a healthy diet, physical activity, and smoking cessation and weight management. Along with the lipid control and early screening, blood sugar and blood pressure management are also key. The four main pillars of therapy include RAS blockade to slow disease progression, SGLT2 inhibitor to reduce the CKD progression and the cardiovascular risk, and GLP-1 receptor agonist to improve the glycemic control and promote the weight loss, and the finerenone to protect against the fibrosis inflammation. Thank you for your attention.